Your surgeon just handed you a consent form. There's a pen in your hand. And somewhere in that document is a risk you were never told about out loud. Today I'm going to tell you what it is, because right now, in hospitals across this country, older adults are going into procedures that are being described to them as routine and coming out permanently changed, not healed. Changed, not talking about rare, freak outcomes. I'm talking about documented, published, peer-reviewed risks that exist in the medical literature. Here's what I want you to do right now. If you are over 60 or someone you love is, and a surgical recommendation is on the table, or might be one day, do not close this video. Because in the next 20 minutes, I'm going to give you the 5 surgeries that carry the most underreported risks for seniors, the exact questions you must ask before agreeing to anything, and the warning signs that tell you to slow down, even when everyone around you is saying, let's move forward. Stay with me. Before we dive into the first surgery, tell me right now in the comments, what is the one procedure you or a loved one are currently debating? Let's talk about it. The human body over 60 is not simply a younger body that has gotten older. It is a different biological environment. And surgery, even a well-performed, technically perfect surgery, interacts with that environment in ways that younger bodies simply do not experience. Think of it like this. Imagine 2 bridges. One was built 5 years ago. Fresh steel, modern materials, well within its load-bearing specs. The other has been standing for 70 years. Both bridges are functional. Both can carry traffic. But if you run the same stress test on both, you get different results. And the engineer who ignores that difference is not being optimistic. They're being careless. Surgery is a stress test, a major one. And here is what it does to a body over 60 that most patients are never told clearly. The heart has reduced functional reserve. It can't ramp up output as efficiently under surgical stress. The lungs clear anesthetic agents more slowly. Breathing complications after surgery are significantly more common in older patients. The kidneys process pain medications and sedatives at a fraction of the speed they did at 40, which means drugs that should clear your system in hours can linger for days, causing side effects that look like confusion, agitation, and cognitive decline, and the brain. This one surprises people the most. There is a well-documented condition called post-operative cognitive dysfunction, or POCD. It is a measurable decline in memory, attention, and executive function that occurs after surgery. And the research on it is unambiguous. Research published in Frontiers in Behavioral Neuroscience confirms that among patients undergoing cardiac surgery, specifically coronary artery bypass, 50 to 70% develop POCD within the first week post-surgery, with 10 to 30% experiencing long-term cognitive effects at the 6-month mark. That is not a footnote. That is a central risk of major surgery in older adults, and it deserves to be part of every pre-surgical conversation. Here is the critical distinction I need you to carry through this entire video. Age alone does not make surgery dangerous. I have watched 82-year-olds recover faster than some 55-year-olds. What matters is not the number on your birth certificate. It is what we call frailty, a clinical measurement of the body's reserve. And published data from Sweden's nationwide registry confirms that among the oldest old, those in their 80s and 90s, 2/3 to 3/4 show evidence of frailty. So the question is never simply, can you survive the operation? The question, the one that should be asked out loud in every surgical consultation, is this: can you survive the recovery? Those are 2 different things, and that distinction is going to matter a great deal right now. This cognitive drop is a massive risk. Be honest. Did your doctor ever warn you that anesthesia could linger and affect your memory like this? Type yes or no in the comments right now. I want to see how common this omission is. Surgery number 1, open heart, surgery in high-risk elderly patients, specifically coronary artery bypass grafting, or CABG, is one of the most performed major surgeries in older adults. And for the right patient, in the right condition, it saves lives. That is unambiguous. But here is what often doesn't make it into the conversation. Open heart surgery requires your heart to be completely stopped. You are placed on a cardiopulmonary bypass machine, a device that takes over the work of your heart and lungs, while surgeons operate on a motionless heart inside an open chest. For a healthy 62-year-old, the body tolerates that. For a 79-year-old with chronic kidney disease, type 2 diabetes, and early cognitive changes, That bypass machine is an extraordinary physiological assault on every major organ simultaneously. The data tells a clear story. A retrospective cohort study of patients aged 75 and older undergoing cardiac surgery found an overall 30-day mortality rate of 17.6%. Among octogenarians specifically, National Cardiovascular Network data involving over 67,000 patients found that those over 80 had 8.1% in-hospital mortality after isolated CABG, nearly triple the rate of younger patients, climbing to 19.6% for combined CABG and mitral valve replacement procedures. And critically, the POCD data on cardiac surgery is particularly striking. 50 to 70% of CABG patients develop measurable cognitive decline within the first week after surgery. So what's the alternative? In many cases today, there is one. It's called TAVR, transcatheter aortic valve replacement. A catheter is threaded through a blood vessel. No opening of the chest, no stopping the heart, no bypass machine. Outcomes data for high-risk elderly patients comparing TAVR to open surgery have shifted the field significantly. Hospital stays are shorter. Cognitive disruption is lower, and in appropriate patient profiles, survival outcomes are comparable. The question you bring to that cardiology office: am I a candidate for a catheter-based approach? If that option hasn't been raised, raise it yourself. Surgery number 2. Complex spinal fusion in older adults. Back pain in people over 60 is nearly universal. I have never seen a patient in their 70s who didn't have something to say about their spine. And when conservative treatments feel like they're stalling, the idea of a surgical fix is genuinely appealing. But here is what peer-reviewed research shows about complex spinal fusion in elderly patients. And I want you to sit with these numbers. A large database study published in PubMed examining Medicare beneficiaries who underwent posterolateral spinal fusion found that complication rates for spinal surgery in elderly patients range from 37% to 80%, with major complications occurring in 12% to 21% of patients. Specifically, patients undergoing fusions of more than 8 levels had a major complication rate of 35.4%. Patients aged 75 to 83 undergoing 5 to 15 level deformity corrections showed perioperative complication rates of 62%, including heart attacks, pulmonary embolism, deep wound infections, pneumonia, and stroke. And here is what may be the most important finding of all for patients considering elective spinal surgery for chronic pain. For patients with degenerative lumbar disease and isolated spinal stenosis, the kind of wear and tear spine degeneration that develops over decades. Clinical guidelines note that fusion has not been shown to improve outcomes compared to decompression alone. And for many patients, well-managed physical therapy, targeted epidural injections, and supervised rehabilitation produce comparable pain relief without the compounding surgical risk. There are absolutely situations where spinal surgery in older adults is essential. Active spinal cord compression, loss of bladder or bowel control, progressive neurological deficit. These are not elective scenarios. But chronic back pain in a stable older adult? That is a conversation, a full one, that should include every non-surgical path before anyone picks up a scalpel. Have you or someone you love been told surgery was the only option for back pain? Drop that in the comments. I read everyone. I hear from patients all the time who feel pushed into the operating room when they just wanted pain relief. Have you ever felt pressured into back surgery? Share your story in the comments below. Your experience might be exactly what someone else needs to read today. Surgery number 3, major cancer resections in frail patients. This is the hardest part of what I have to tell you today, and I'm going to ask you to stay with me through it, because it matters deeply. When someone hears cancer, the instinct is immediate and powerful. Remove it. Cut it out. Whatever it takes. I understand that. Completely. I would feel the same way. But 2 decades in medicine have taught me this. The goal of treatment is not simply to eliminate the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the opposite. Here's the data. A study presented at the American Association for Thoracic Surgery examined over 2,800 patients who underwent lung cancer resection. Among elderly patients aged 80 and over who experienced major post-operative complications, the failure to rescue rate, meaning death following a complication the body could not overcome, was 12%, compared to 5.6% in younger patients. The risk of failing to rescue increased by approximately 50% per decade of age. For pancreatic cancer surgery, the Whipple procedure, which involves 6 to 10 hours of surgical time and removal of multiple abdominal structures, the complexity is extreme. Published data from the Journal of the American College of Surgeons showed that 5-year survival in octogenarians after pancreatectomy was just 11%, and outcomes in patients with multiple comorbidities were substantially worse. The honest oncology question that every patient deserves to have answered. For someone with my specific age, health profile, and tumor characteristics, how do outcomes compare between surgery, radiation, targeted therapy, and watchful monitoring? That question opens a door many patients never knew existed. Surgery number 4, elective joint replacement in medically complex patients. Hip and knee replacements have transformed quality of life for millions of people. The right patient, one who engages in rehabilitation, tolerates anesthesia well, and has adequate nutritional reserves, can go from barely walking to hiking trails within 6 months. I have seen it. It is real, and it is remarkable. But here is the nuance. The word elective means you have time enough to ask the right question, not, should I ever have this surgery? But, is my body in the best possible condition right now? In older adults carrying multiple serious conditions simultaneously, uncontrolled blood pressure, type 2 diabetes, chronic kidney disease, significant obesity, the risk calculation changes meaningfully. The most serious threat is deep vein thrombosis, blood clots forming in the deep leg veins during the reduced mobility recovery period. In elderly patients with compromised circulation, those clots can travel to the lungs as a pulmonary embolism, a life-threatening event that can unfold within 48 hours of discharge. Add hospital-acquired pneumonia from reduced mobility. Add surgical site infection risk in patients with impaired immune function. Add the well-documented risk of post-operative delirium in elderly patients who cannot hear or see clearly when they wake up in an unfamiliar environment. Here is what actually moves the needle before elective joint replacement, prehabilitation. A deliberate 4 to 8 week program of daily walking, increased protein intake, blood sugar optimization, and blood pressure control before the surgical date that builds the body's reserve so the person walking into that operating room is measurably stronger than they were when surgery was first recommended. Some hospitals now formally require prehabilitation before scheduling these procedures in high-risk elderly patients. That is exactly the right approach. Has your surgeon ever discussed prehabilitation with you? Prehabilitation changes everything. If this is the very first time you are hearing the word prehabilitation, type the word "new" in the comments. We need to make this a standard conversation in every clinic. And if you are finding all information valuable, kindly press that like button and subscribe to my channel. Surgery number 5, emergency abdominal surgery. This one is different from the others, and I want to be clear about why. You do not choose emergency surgery. A perforated bowel, a ruptured appendix, acute internal bleeding. These situations do not wait for calm conversations or second opinions. They arrive at 2 a.m. and demand immediate decisions. So why is it on this list? Because knowing the risks before the emergency happens changes how families navigate those terrifying corridor moments, and because prevention is the most powerful intervention in medicine. Here is the data. A 2024 study published in the World Journal of Surgery examining 754 patients undergoing major emergency abdominal surgery found 30-day mortality rates ranging from 8% to 25%, climbing as high as 50% among octogenarians depending on diagnosis and severity. A systematic review published in the Journal of the American Geriatric Society confirmed that in-hospital mortality for emergency colonic operations in patients aged 90 and older reached 42% in some centers. Even for bowel obstruction surgery specifically, a 2022 study found in-hospital mortality of 18.2% in adults over 75 compared to 8.9% in younger patients. The reason is not surgical skill, it is the physiological cascade. When an older body is hit simultaneously by trauma, blood loss, anesthetic burden, and the inflammatory response that follows major abdominal disruption, organs that have reduced reserve begin failing in sequence. What a younger body resolves within days can spiral in an older body into multi-organ dysfunction. And by that point, medicine's options narrow rapidly. What you can do with this? First, don't ignore early warning signs: persistent abdominal pain, unexplained bloating, significant changes in bowel habits, or blood in stool in anyone over 60 warrants prompt medical evaluation. Catching these problems early almost always means smaller, less invasive treatment, and dramatically better outcomes. The best emergency surgery is the one that never becomes necessary. Second, have the conversation with your family now. Not in a hospital corridor at midnight. Now, what are your wishes if emergency surgery is presented as the only option? What quality of life matters to you? These conversations are not morbid. They are among the most loving things you can do for the people who would otherwise be making decisions in crisis without guidance. The 4 questions, plus red flags. Now let's talk about what you actually do with everything we've covered. Because information without action is just anxiety, and that's the last thing I want for you. Before any major surgery, planned or recommended, every patient over 60 should ask 4 questions. Write these down. Question 1. What happens if I don't have this surgery, and over what time frame? A good surgeon gives you a specific, honest picture. If the answer is vague or designed to alarm rather than inform, you don't yet have what you need. Question 2. Is there a less invasive alternative? Robotic surgery, catheter-based procedures, endoscopic approaches, targeted injection therapies, optimized medical management. These are not fringe options. They exist in most major hospitals. If none of them came up, ask directly. Question 3. What does recovery specifically look like for someone with my health profile, not the average patient? You, your kidneys, your cardiac history, your medications, your living situation. The answer should be specific. Vagueness here is a warning sign. Question 4. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. A confident, honest surgeon will answer directly. If the question creates discomfort or deflection, pay close attention to that reaction. Planned elective surgery almost never has true urgency. A knee that's hurt for years doesn't suddenly need to be on the schedule within 2 weeks unless something clinically significant has changed. If pressure is coming before you've had time to think, if you leave a consultation with exactly one option, surgery, and no mention of anything else, that consultation is incomplete. Request the full picture. Doing nothing was never discussed. Watchful waiting with active monitoring is a legitimate, evidence-based medical strategy. If no one has described what conservative management looks like for your situation, you haven't yet received a complete answer. Your questions create tension. A surgeon who would demand those same questions before their own parent's procedure should welcome them from you. If they don't, that discomfort is information. Recovery was glossed over. If you and your medical team decide surgery is the right path, and for many conditions it genuinely is, what you do in the 2 to 4 weeks before that operating room matters more than most patients ever realize. Prehabilitation, daily walking, even 15 to 20 minutes, to build leg and lung reserve. Deliberate protein increase because protein is the raw material your body rebuilds tissue with, and most adults over 65 are quietly protein deficient. Blood sugar and blood pressure optimization, because both directly affect wound healing and clotting risk. If you smoke, even stopping 2 to 3 weeks before surgery measurably reduces pulmonary and wound healing complications. The anesthesia conversation. Request a preoperative consultation with your anesthesiologist, not a brief hallway exchange. Bring every medication and supplement you take. Ask whether a regional or spinal anesthetic, numbing only the surgical area rather than placing your entire brain under general anesthesia, is appropriate for your procedure. For many hip and knee operations it is. And here's one that sounds almost too small to matter. If you wear hearing aids or glasses, arrange to have them with you until the last possible moment before you go under, and back the moment you wake up. Research on hospital delirium is clear. Patients who can see and hear their environment as they emerge from anesthesia experience significantly less post-operative confusion. 5 surgical procedures that carry serious underreported risks for adults over 60. Open heart surgery in frail patients, where catheter-based alternatives now have strong outcomes data. Complex spinal fusion, where complication rates in elderly patients reach 37 to 80% in the literature, and where conservative management often delivers comparable pain relief. Major cancer resections in frail patients, where the failure to rescue rate doubles with age and where the goal must always be more good years of life. Elective joint replacement in medically complex patients, where timing, preparation, and prehabilitation matter as much as the procedure itself. An emergency abdominal surgery, where 30-day mortality among octogenarians can reach 50% in severe cases, and where prevention and early detection are the most powerful interventions available. None of this means avoid surgery. Surgery saves lives every single day. I've been part of that. I am proud of it. What it means is, be an informed patient. Ask the hard questions. Request the alternatives. Prepare your body. Get the second opinion. And bring someone with you to every major consultation. Because fear has a way of narrowing what we hear. And a calm second set of ears in the room may be the most valuable thing you bring through that door. What question would you most want to ask before agreeing to surgery? Tell me in the comments. This gave you something real today. Share it. With a parent, a spouse, a sibling, a friend sitting on a surgical recommendation they're not sure about. That one share might be the most important thing you do today. Take care of yourselves. Stay curious. And keep advocating fiercely, because no one will ever do it with more commitment than you.